Hello everyone, how are you doing? Hope your preparation is going on good. Yes? So after this session maybe your physiology preparation will also be very strong. We will discuss four systems, mainly respiratory system, cardiovascular system, central nervous system and renal system. So let us jump straight into the revision. First one we will discuss is respiratory system. Okay. Now when we talk about respiratory system, we have the respiratory passages which are divided into many branches. So total, if we see all the branches, that divisions is 23 divisions. And this divisions is given by Weibull. So it is known as Weibull's classification. Among these 23 divisions, the first 16 divisions, they form the anatomical dead space. So there is no diffusion of gases going on in this. Anatomical dead space means no diffusion of the gases is going on. And last seven generations is known as respiratory zone. Respiratory zone because here the diffusion of gases starts. Fine. And this anatomical dead space, if we see how much is the volume, then it is 150 ml, right? And we can calculate this as 2 ml per kg of the person. So if we know the weight of the person, then simply multiply that weight with 2 ml and it will give you the dead space value. Then next topic in respiratory system is mechanics of respiration. When we talk about mechanics of respiration, basically we are talking about the mechanism how air is moving in and how air is moving out. So dekhe how it is going in. बोला this is respiratory passages. Simplified diagram I will draw. तो ये respiratory passages हो गए, ये alveoli हो गया. अब for air to move from outside to inside, we want negative pressure inside the alveoli. So it is -1 millimeter mercury. -1 meaning it is 1 millimeter less than that of the atmospheric pressure. So atmospheric pressure at sea level is 760 millimeter mercury. So inspiration में alveolar pressure is how much? Actually it is 759 millimeter mercury. Okay, -1 millimeter mercury. Then air will move into. And similarly we have the pleural pressure also. So we should talk about both pleural and the alveolar pressure. So we will just summarize that what is the alveolar and pleural pressure in inspiration and expiration. Okay, so let me just draw. So here it is, we will write pleural pressure. Then we have the alveolar pressure. Inspiration, how much is the pressure? And expiration, how much is the pressure? So inspiration, pleural pressure goes to -6 millimeter mercury and alveolar pressure is -1 millimeter mercury. Both are negative pressures. In expiration, pleural pressure is still negative. Pleural pressure is always negative except in forced expiration. Okay, so it is -2.5 millimeter mercury. And alveolar pressure becomes +1 millimeter mercury. It should be 1 millimeter higher than that of the atmospheric pressure. तो ये तुम्हारा हो गया mechanics of respiration. This is the fundamental which we should remember. Then next topic in respiration है compliance. What is compliance? Compliance is change in volume in the respiratory system divided by the change in the pressure. Delta V by delta P. इसको कहते हैं compliance. और why it is important to know this? अगर compliance कम हो जाता है, if compliance decreases, then it is known as restrictive lung diseases. Okay, compliance में problem है तो उसको कहते हैं restrictive lung diseases. Now this compliance is basically affected by two factors. One is the elasticity of the lung and the other is known as surface tension. We will not talk about elasticity, we will talk about surface tension because there is a protein which is released, that is the surfactant. Actually it is a major composition is lipid. Okay, surfactant proteins are also there, surfactant protein A, B, C, like that. And major composition of this surfactant is dipalmidyl phosphatidyl DPPC. This surfactant is released from type 2 pneumocytes. And what is the function of this surfactant? Surfactant decreases the surface tension. देखो अगर if this is the alveoli और यहाँ पे surface tension है, surface tension वहाँ पे होता है where there is contact of air with the fluid, तो वहां पे surface tension develop होता है, and surface tension will cause the alveolar to collapse, alveoli to collapse, tendency of collapse is going to increase, बंद होने लगेगी alveoli. तो surfactant क्या करता है, it decreases the surface tension. Because of this, the tendency of collapse of the alveoli decreases. So basically क्या कर रहा है surfactant? Surfactant is increasing the compliance. ओके क्योंकि कोलैप्स नहीं हो रहा है तो इसका मतलब है एक्सपेंशन हो रहा है, सो इट इज इंक्रीजिंग द कंप्लायंस. नाउ इफ this surfactant is not there, so there is a disease known as infant respiratory distress syndrome, also known as hyaline membrane disease. So it happens in premature infants, basically less than 28 weeks, because in them surfactant is not released, the quantity of surfactant is very less, so in them the surface tension is high and this ultimately leads to respiratory distress. ठीक है, तो function of surfactant you should remember, it decreases the surface tension, that is why it decreases the alveolar collapse, and also it decreases the work of breathing. Okay, so this is all about the surfactant we should know. हाँ, एक और चीज, that this surfactant secretion, it is increased by corticosteroids and also it is increased by thyroid hormones. Then it is decreased by insulin. ठीक है, it is decreased by insulin, very important to remember. Then there is something known as LS ratio, lecithin into sphingomyelin ratio. Normally this is greater than 2, in premature infants it is less, so it is used to assess lung maturity in fetus. ठीक है, so that is all about the surfactant. Abhi next topic, that is lung volumes and capacities. So in very brief we are discussing all the salient features which are important for each system. Okay, so lung volumes and capacities. अब lung volumes and capacities, when we talk about two types of lung volumes and capacities, that is static lung volume and capacity and dynamic lung volume and capacity. Static, that spirogram which we discussed, so I will just draw the spirogram. ठीक है, so like this we draw the spirogram. So this is the tidal volume. Then when we take deep inspiration, यहाँ से जब देखो ये normal inspiration है, this is the normal inspiration. When we take deep inspiration from there, then this forms the inspiratory reserve volume. इतना body में reserve है, it can take more inhalation up to that reserve, so that is known as inspiratory reserve volume. Then this again coming back to the tidal volume. Okay, then if we exhale from here, that is this is the end tidal expiration, normal resting condition में जो expiration है उससे ज़्यादा if we exhale, more than that of the resting condition if we exhale, then it is known as expiratory reserve volume. Expiration का भी reserve है body में, then it comes back. Okay, so now what are the static lung volumes and capacities? Static lung volumes and capacities include tidal volume, inspiratory reserve volume, expiratory reserve volume, and even after expiration there is some air which is remaining in the lungs and this is known as residual volume. ठीक, तो ये तो हो गया lung volumes. Then there are capacities. What are the lung capacities? इसमें we just have to add, when we add inspiratory reserve volume and the tidal volume, it is known as inspiratory capacity. Then when we add expiratory reserve volume and the residual volume, it is known as functional residual capacity. पूरा ले ले, how much air is present in the lungs totally? When we take deep inspiration, then total amount of air which is present in the lungs, that is known as total lung capacity. And what is vital capacity? Vital capacity is this much, IRV plus tidal volume plus ERV, this is known as vital capacity. So फटाफट tell me what are the values of these? Values will come to, tidal volume is 500 ml, inspiratory reserve volume is 3 liters, 3000 ml, expiratory reserve volume is 1.1 liter, 1100 ml, residual volume is 1.2 liter, that is 1200 ml. So if you know the values of these, we can easily calculate the values of the various capacities. अच्छा, इसमें one question will be there that in spirometry, by spirometry which of these cannot be measured? Basically the volume which is remaining in the lungs cannot be measured. देखो, everything can be inhaled from some external source and can be exhaled out, but there is certain volume which is remaining in the lungs which cannot be exhaled out, so that is known as residual volume. So residual volume cannot be measured. अगर residual volume we cannot measure, तो you see residual volume is part of ERV also, FRC also, right? FRC is ERV plus residual volume. So we cannot measure FRC also by spirometry, and we cannot measure total lung capacity also by spirometry. So that is the static lung volume and capacity. Coming to dynamic lung volume, when we talk about dynamic lung volume and capacity, we have FEV1, post expiratory volume in 1 second, and we have FVC, post vital capacity. So iska ratio is very important. Normally this ratio is more than 0.8. When this ratio becomes less than 0.7, 0.7 से अगर कम हो जाता है, then that is known as obstructive lung disease. Okay, obstructive lung disease. When this ratio is less than 0.7, that is obstructive lung disease. There is another disease, that is restrictive lung disease, जिसमें I told you before compliance कम हो जाता है. तो if compliance decreases, तो FVC भी decrease होता है और FEV1 भी decrease होता है. देखो obstructive lung disease में FEV1 decreases, ठीक है, जितना हम एक्सपायर कर रहे हैं, एक्सहेल कर रहे हैं, दैट डिक्रीजेस, क्योंकि ऑब्स्ट्रक्टिव लंग डिजीज इज ड्यू टू इंक्रीज्ड एयरवे रेजिस्टेंस, तो FEV1 इंक्रीजेस. लेकिन रिस्ट्रिक्टिव लंग डिजीज दोनों डिक्रीज हो जाते हैं, FEV1 भी also decreases and FVC also decreases. So because there is proportionate decrease in FEV1 and FVC, so that is why this ratio is normal. In fact कभी कभी थोड़ा ज्यादा भी हो जाता है, क्योंकि FVC if it decreases too much then this ratio can increase also. तो ठीक है, so that was about obstructive and restrictive lung disease. चलो अब next topic we will go on. What is the next topic in respiration? That is flow volume loop. Okay, तो flow volume loop में क्या होता है? तो as the name is suggesting, flow volume loop, how is this? See, I'll just draw the graph. Okay, तो इसमें जो ग्राफ है इट विल बी फ्लो वॉल्यूम ड्यूरिंग इंस्पिरेशन एज वेल एज एक्सपिरेशन. तो यहाँ पे हो जाएगा वॉल्यूम एंड वाई एक्सिस इज फ्लो. फ्लो इज बेसिकली टेलिंग वॉल्यूम विच इज मूविंग पर यूनिट टाइम. तो वी विल स्टार्ट फ्रॉम हियर, दिस इज नोन एज रेजिडुअल वॉल्यूम, क्योंकि वी विल टॉक अबाउट द इंस्पिरेशन. सो व्हेन वी इनहेल फ्रॉम रेजिडुअल वॉल्यूम वी रीच टू द total lung capacity, maximum inhalation is occurring. ठीक है, so this is the inspiration curve, and then if we exhale from total lung capacity to the residual volume, graph is something like this. Okay, ये straight रहेगा. Okay, so total lung capacity to residual volume, तो ये phase of expiration हो गया. So this is normal, but what you should know is abnormal. So in abnormal, this graph will become abnormal both in obstructive lung disease and restrictive lung disease. So in obstructive lung disease किसमें problem है? Airway resistance में main problem है. तो ये जो इधर है lung filling, actually वो थोड़ी ज्यादा होती है, okay, क्योंकि exhale the person is not able to exhale completely. तो the graph is something like this, and then here is a scooping. Okay, it goes like this. Okay, so this is obstructive lung disease flow volume loop. और restrictive lung disease में क्या होगा? Because I told you restrictive lung disease compliance is less, तो filling of the lungs is decreased. तो यहाँ से ग्राफ शुरू होगा, ठीक है, और it will end here. तो restrictive का, so it is not able to fill much, and यहाँ पे ये it will go like this. ठीक है, तो देखो पीक तो इट विल डिक्रीज क्योंकि वॉल्यूम इज लेस, सो पीक इज गोइंग टू डिक्रीज, बट द ग्राफ हैज शिफ्टेड टू दिस साइड बिकॉज द टोटल वॉल्यूम हैज डिक्रीज. सो दिस इज अ ग्राफ ऑफ रिस्ट्रिक्टिव लंग डिजीज. तो ये तुम्हारा हो गया फ्लो वॉल्यूम लूप. ठीक है, नेक्स्ट टॉपिक इन रेस्पिरेशन इज ऑक्सीहीमोग्लोबिन डिसोसिएशन कर्व. ऑक्सीहीमोग्लोबिन डिसोसिएशन कर्व वेरी इंपॉर्टेंट टॉपिक. क्या होता है ऑक्सीहीमोग्लोबिन डिसोसिएशन कर्व? जैसे कि इट्स नेम इज टेलिंग, इट्स द कर्व बिटवीन ऑक्सीजन एंड हीमोग्लोबिन. तो कैसे है? दिस इज द पार्शियल प्रेशर ऑफ ऑक्सीजन एंड हियर tell hemoglobin percentage saturation. मतलब how much percentage of hemoglobin has bound with oxygen. तो normally this graph it will be like this, okay? And इसमें एक चीज याद रखनी है, P50. P50 is the partial pressure of oxygen at which hemoglobin is 50% saturated. तो यहाँ पे ड्रॉ कर देते हैं, ये 50% हो गया, and partial pressure of oxygen it is at which 50% saturated, ये वैल्यू इंपॉर्टेंट है, it is 26 millimeter mercury. ठीक, partial pressure of oxygen at which hemoglobin is 50% saturated, that is known as P50. तो ये तो normal graph है. Now there is shift of the graph to the right and to the left. So I'll just draw, this is the right shift and this is the left shift. Right shift of the graph and left shift of the graph. When does right shift occur? Right shift होगा, सब चीजें बढ़ जाएंगी, that is hydrogen ions increase, carbon dioxide increase, then 2,3 BPG increase. ठीक है, लेकिन partial pressure of oxygen decrease. जब hypoxia होगा then we will get right shift. Why? Because when there is hypoxia it leads to increase in 2,3 BPG. ठीक, so that is right shift. When does left shift occur? Opposite of this thing. So there is hydrogen ions decrease, partial pressure of carbon dioxide decrease. इसमें temperature भी लिख लो, right shift temperature increase. तो इसमें भी temperature decrease, okay? And hydrogen ions, partial pressure carbon dioxide, temperature and 2,3 ppg also decrease. So that will all lead to left shift. But there are certain other important points in left shift, that it also occurs in fetal hemoglobin. Fetal hemoglobin has a very high affinity for oxygen. तो उसमें लेफ्ट शिफ्ट होता है. और दूसरा है कार्बन मोनोऑक्साइड पॉइजनिंग. Carbon monoxide poisoning is also left shift. Also you remember that carbon monoxide has a 250 times affinity for hemoglobin. Important, 250 times affinity for hemoglobin compared to that of oxygen. So if carbon monoxide is there in the circulation, it will preferably bind to hemoglobin. लेकिन जितना ऑक्सीजन बेचारा बाइंड भी कर पाया है वो भी अब रिलीज नहीं हो पाएगा, बिकॉज इट इज लेफ्ट शिफ्ट. सो दैट ऑल्सो विल हैव डिफिकल्टी इन रिलीजिंग. ओके, राइट शिफ्ट मतलब क्या है कि नाउ ऑक्सीजन इज गोइंग टू बी रिलीज. राइट शिफ्ट बेसिकली मीन्स डिक्रीज इन O2 एफिनिटी और लेफ्ट शिफ्ट मीन्स इंक्रीज इन एफिनिटी ऑफ हीमोग्लोबिन फॉर ऑक्सीजन. ठीक है, तो बहुत इंपॉर्टेंट टॉपिक है ये. देन इन दिस देयर इज सम कॉन्सेप्ट नोन एज बोर इफेक्ट and Haldane effect. क्या है ये? Bohr effect is the effect of carbon dioxide on the transport of oxygen. तो ये देखो क्या है इधर, when carbon dioxide increases, oxygen is being released. Where it is happening? It is happening at the level of tissues. Bohr effect. Because tissues are continuously metabolizing, so carbon dioxide increases, oxygen is released. Haldane effect is opposite. Haldane effect is the effect of oxygen on the transport of carbon dioxide. ठीक है, तो oxygen if it is getting released, carbon dioxide will bind more. और या उल्टा, if oxygen is getting bound, then carbon dioxide will be released. ये कहाँ होता है? Oxygen is getting bound, carbon dioxide is being released. That is happening in case of lungs. ठीक है, बोर इफेक्ट एंड हैल्डेन इफेक्ट. तो ये तुम्हारा हो गया ऑक्सीजन हीमोग्लोबिन डिसोसिएशन का बहुत इंपॉर्टेंट टॉपिक. देन मूविंग ऑन टू द नेक्स्ट टॉपिक ऑफ रेस्पिरेशन. तो नेक्स्ट टॉपिक में क्या होगा? दैट इज द रेगुलेशन ऑफ रेस्पिरेशन. सो व्हाट टू रिमेंबर इन रेगुलेशन ऑफ रेस्पिरेशन? फर्स्ट ऑफ ऑल, व्हाट इज द पेसमेकर? सो पेसमेकर इज प्री-बॉड्जिंगर कॉम्प्लेक्स. Then there is DRG center. This is in medulla. DRG, VRG, all these three. Pacemaker, DRG, VRG is in medulla. DRG has I neurons, which is for inspiration. VRG has I and E neurons, both for inspiration as well as expiration. Expiration means mainly in forced expiration it works, not in tidal expiration. Tidal expiration is passive, so forced expiration. Then we have apneustic center. Apneustic center is responsible for increase in the depth of the respiration. So ये increase in depth of respiration करता है. Then we have the pneumotaxic center. Pneumotaxic center is for increase in the rate of the respiration. तो pneumotaxic center का याद रखो कि it is causing the switch फ्रॉम इंस्पिरेशन टू एक्सपिरेशन, फ्रॉम एक्सपिरेशन टू इंस्पिरेशन, ठीक है, स्विच फ्रॉम इंस्पिरेशन टू एक्सपिरेशन, ये याद रखो क्योंकि ये नीमोटैक्सिक सेंटर इनहिबिट करता है एपन्यूस्टिक सेंटर. सो नीमोटैक्सिक सेंटर इंपॉर्टेंट फॉर इंक्रीजिंग द रेट ऑफ रेस्पिरेशन, एपन्यूस्टिक सेंटर इंक्रीजिंग for increasing the depth of respiration. Now here only let us talk about some abnormal respirations. Abnormal respiration. So abnormal respiration, first of all, because we talked about apneustic center, remember apneusis. Apneusis means apneustic center क्या है? Increase in depth of respiration. तो apneusis में क्या होता है? Increase in depth और maintain and then it comes down. So this is known as apneusis. Okay. ऐसे इंस्पिरेशन करता है, लंबा इंस्पिरेशन एंड देन देयर इज सडन एक्सपिरेशन, सो दैट इज एपन्यूसिस. अनदर इज चेन स्टोक्स रेस्पिरेशन. व्हाट इज चेन स्टोक्स रेस्पिरेशन? दैट इज देयर इज slowly there is increase in the rate and depth of the respiration, it reaches maximum, फिर ऐसे कम होगा and then it will be apnea. So there will be apnea in slowly increase in rate and depth and then followed by decline in this rate and depth and then followed by apnea. Then again this cycle is going to continue. So that is chain Stokes respiration. Then what is Biot's respiration? Biot's respiration is irregular burst of inspiration and then there is small pause. Irregular inspiration, small pause. This is Biot's breathing. Then what is tachypnea? Tachypnea क्या होता है? Tachypnea is increase in the rate of respiration. And what is hyperapnea? Hyperapnea is increase in the depth of respiration. ठीक है, hyperapnea means depth of respiration increase होगा, tachypnea means increase in the rate of the respiration. ठीक है, ये तुम्हारे हो गए abnormal respiration और neural regulation भी also we discussed. Then next point is hypoxia. What is hypoxia? Hypoxia is decrease in the oxygen availability at the level of the tissue. So there are 4 types of hypoxia. So let us draw, say suppose this is the circulation, ठीक है, and here there are tissues, cells are there, and here there is alveoli. So first is that there should be, lungs should bring in oxygen from outside, so there should be entry. So this is for partial pressure of oxygen. If this is not happening, then it is known as hypoxic hypoxia. Hypoxic hypoxia. Also hypoxic hypoxia is also known as hypoxemia. Hypoxemia. What is the main problem? There is decrease in the partial pressure of oxygen in the blood. When it will happen? It will happen in case of high altitude, क्योंकि atmosphere में ही oxygen is less, so it is high altitude. Then we have lung diseases. Then in case of right to left shunts in heart, क्यों तो वो पूरा bypass कर देगा lung को, so the blood will directly enter from right side to left side of the heart. तो ये हो गया hypoxic hypoxia. Then it comes ischemic hypoxia. That is second, ischemic hypoxia, because once this oxygen enters, it should bind with hemoglobin. But if hemoglobin is less, then that is known as this is not ischemic hypoxia, it is anemic hypoxia. Anemic hypoxia, ठीक है, anemic hypoxia, and hemoglobin is less, RBC count is less, so that is the main problem. Partial pressure of O2 is normal. Third one is stagnant hypoxia. Stagnant hypoxia, another name is ischemic hypoxia. That means partial pressure of oxygen is okay, hemoglobin is okay, but blood is not flowing. We want the blood to flow and carry the blood to the tissues. So if blood is not flowing, then that is stagnant or ischemic hypoxia. And finally we have the histotoxic hypoxia. That is the fourth kind, histotoxic hypoxia. So इसमें PO2 is also normal, hemoglobin is also normal, blood flow is also normal, but tissue is not able to utilize the oxygen. In which condition it occurs? Cyanide poisoning and beriberi. Okay, beriberi cyanide poisoning important. Stagnant ischemia, stagnant or ischemic hypoxia किसमें होता है? That is in congestive heart failure. Okay, congestive heart failure. Locally also it can occur. Locally, if there is compression of the vessels is there, excessive vasoconstriction is there, then also hypoxia is there. Then moving on to the next topic, last topic in respiration, that is ventilation perfusion ratio. ठीक है, ventilation perfusion ratio. तो if suppose this is the lungs, these are the lungs, तो how much is the ventilation of the lungs? ventilation of the lungs we can calculate by tidal volume into respiratory rate. लेकिन when we are inhaling the air, then some amount of air is remaining in the dead space. I told you that it is 150 ml. Tidal volume is how much? 500 ml. तो for the ventilation of the lungs हमें कैसे calculate करना है? We have to subtract tidal volume with the dead space, anatomical dead space से, and into respiratory rate we will do. तो ये कितना हो जाएगा? 500. Tidal volume is 500 ml. Dead space is 150 ml. तो it will come 350 ml into the respiratory rate, say 12 per minute. It comes to 4.2 liters. So ventilation is 4.2 liters. Perfusion is how much? Perfusion, because lungs are getting full volume from the heart, तो perfusion is 5 liters. ठीक है, राइट वेंट्रिकल से पूरा ब्लड जो है लंग्स में आ जाता है. सो वी होल कार्डियक आउटपुट इज इन लंग्स. सो दिस इज वेंटिलेशन परफ्यूजन रेशियो. इनको डिवाइड कर दो तो इट विल कम टू 0.8. ठीक है. सो दिस इज द एवरेज वेंटिलेशन परफ्यूजन रेशियो, पर इट डिफर्स इन वेरियस पोर्शन ऑफ द लंग्स. तो वी हैव वेंटिलेशन एट एपेक्स एंड वेंटिलेशन एट बेस. तो अगर इसका डायग्राम आई ड्रॉ, वेंटिलेशन एट बेस इज मोर. ओके, तो वी विल ड्रॉ फ्रॉम बेस टू एपेक्स. वी विल ड्रॉ बेस टू एपेक्स. ठीक है, यहाँ पे है बेस. वी आर ड्रॉइंग द ग्राफ. सो दिस इज द बेस एंड दिस इज द एपेक्स. तो बेस में इट इज मोर, एपेक्स में इट इज लेस वेंटिलेशन. देन परफ्यूजन. परफ्यूजन इज ऑल्सो सेम, बट इट इज लाइक दिस. ओके, ज्यादा डिक्रीज होगा परफ्यूजन. तो बेस में वेंटिलेशन इज ऑल्सो मोर, बेस में परफ्यूजन इज ऑल्सो मोर. एपेक्स में वेंटिलेशन इज ऑल्सो लेस, परफ्यूजन इज ऑल्सो लेस. लेकिन परफ्यूजन कुछ ज्यादा ही लेस है. ठीक है, तो अगर हम रेशियो देखें तो सीधे वेंटिलेशन इज डिक्रीजिंग बट परफ्यूजन इज डिक्रीजिंग टू मच. सो दैट इज वाई दिस रेशियो इज गोइंग टू इंक्रीज. सो एपेक्स में जो वेंटिलेशन परफ्यूजन रेशियो होता है इट इज 3 अप्रोक्सीमेटली. ठीक है, तो एपेक्स में सबसे ज्यादा वीपी रेशियो होता है, बट वेंटिलेशन इज लेस, परफ्यूजन इज लेस, वीपी रेशियो इज मोर एट एपेक्स. ओके, सो दैट कंप्लीट्स आवर रेस्पिरेटरी सिस्टम. अब नेक्स्ट सिस्टम पे जाएंगे, दैट इज द कार्डियोवास्कुलर सिस्टम डायरेक्टली. ओके, सो व्हाट इज वी विल डिस्कस इन कार्डियोवास्कुलर सिस्टम. तो पहला वी विल डिस्कस अबाउट द पेसमेकर. तो एसए नोड इज द पेसमेकर. ठीक है, एसए नोड, व्हाई इट इज द पेसमेकर? Because it generates impulses at maximum rate. Maximum rate पे impulses generate करता है. If there is conductivity talk, we talk in conductivity. Say suppose this is the heart. Okay, so here is SA node, here is AV node. So how it is conducting from SA node to AV node? Then there is bundle of his, which is dividing into left and right branches, and which continues left and right branches continue as Purkinje fibers. ठीक है, Purkinje fibers. तो इसमें जो ये कंडक्टिंग पाथवे है, ऑल ऑफ देम जनरेट इम्पल्स, बट एसए नोड जनरेट्स द मैक्सिमम नंबर ऑफ इम्पल्स. दैट इज व्हाई एसए नोड इज नोन एज द पेसमेकर. और बाकी जो पेसमेकर्स हैं वो दे गेट सप्रेस्ड. सो दैट इज नोन एज ओवरड्राइव सप्रेशन. Overdrive suppression. SA node is overdriving them, it is suppressing them. ठीक है, तो दो चीजें it is important, that what is the rate at other points and what is the conduction velocity. Rate is how much? SA node का rate is approximately 60 to 100 beats per minute. ठीक है, then AV node, bundle of his, the rate of impulse generation is 40 to 60 beats per minute. And Purkinje fiber, it is 15 to 40 beats per minute. तो जैसे जैसे we progress down, you see the number of impulses generated is decreasing. ठीक है, then conduction velocity very important. Purkinje fiber की fastest conduction velocity है, fastest. It is how much? It is 4 meter per second. Then one more thing you remember, that AV node, there is a delay in AV node. Impulse conduct हो रहा है from SA node till the Purkinje fibers, but AV node there is a delay. And how much is the delay? 0.1 second is the delay. ठीक, moving on to the next point in cardiovascular system, that is the pacemaker potential and ventricular action potential. So what is this pacemaker potential and ventricular action potential? Let me just quickly draw the graphs. You can identify which one is what, right? तो ऐसे ग्राफ ड्रॉ होगा. What is this? ठीक है, and next one will be like this. तो ये फर्स्ट वाला इज एसए नोड, एसए नोड एक्शन पोटेंशियल, इसको कहते हैं स्लो एक्शन पोटेंशियल, ऑल्सो स्लो रिस्पॉन्स एक्शन पोटेंशियल. And next one is the ventricular or atrial action potential. तो इसमें some things you should remember. First thing is that this SA node action potential, this phase, this is known as prepotential, and it is due to two aspects. One is the HCN channels, okay, and second is T-type calcium channel, transient calcium channel. HCN channel से sodium will enter. So first part of this phase is due to the entry of the sodium channels, and second part of this phase is due to the entry of the calcium ions. Then this part is due to L-type calcium channels. L-type calcium channel. तो ये phase of depolarization जो है L-type calcium channel की वजह से है, और इसमें जो है again there is entry of calcium ions. Important to remember. ठीक है. Then phase of repolarization, again voltage gated potassium channels, and there is efflux of potassium ions. ठीक है. तो prepotential, entry of sodium ions and calcium ions. Depolarization, L-type calcium channels, entry of calcium ion. Repolarization, voltage gated potassium channel, efflux और exit, potassium बाहर जा रहा है, moving out, potassium moving out. ठीक है. Ventricular and atrial action potential, first phase is due to sodium ions entry. Remember, voltage gated sodium channels open, sodium ion entry. फिर this is early repolarization. Early repolarization, potassium is moving out. Potassium हमेशा बाहर जाता है, simple thing you remember. Early repolarization, potassium is moving out. Then this is the plateau phase. Plateau phase में two things are happening, that calcium moves in, potassium moves out. एक positive ion अंदर आ रहा है, potassium positive ion moving out, तो there is a balance, so voltage change will not occur, so it is a plateau. Then we have the late repolarization phase. इसमें again potassium is moving out. When potassium moves out, phase of repolarization occur. Then in this you remember that heart muscle cannot be tetanized, cannot be tetanized क्योंकि it has a long refractory period. Long refractory period. Okay, this is the reason for this. Why there is long refractory period? Because of this plateau phase of the potential. ये जो plateau है ना, जब तक कि action potential रहेगा, depolarization phase till the time it is there, second impulse cannot stimulate it. So because of this plateau phase, second impulse cannot stimulate the cardiac muscle. So we have a long refractory period, and because of this long refractory period, it cannot be, heart muscle cannot be tetanized. Okay, तो ये भी हो गया. We discussed about the potential. Very important topic now we will discuss, that is cardiac cycle. ठीक है, cardiac cycle. What is cardiac cycle? Cardiac cycle है मतलब एक बीट में, in one beat what is happening, that is cardiac cycle. तो one beat is approximately 0.8 seconds. ओके, तो इसमें क्या होता है, हार्ट कॉन्ट्रैक्ट करता है, दैट इज सिस्टोल, एंड देन द हार्ट डायलेट्स, दैट इज डायस्टोल. हार्ट रिलैक्सेस, दैट इज डायस्टोल. तो वी हैव सिस्टोल एंड वी हैव डायस्टोल. सिस्टोल is 0.3 seconds and diastole is 0.5 seconds. And when we are talking about this term, we are directly relating to ventricular systole and ventricular diastole. Okay, systole 0.3 second, diastole 0.5 second. What are the phases in systole? Heart is contracting, so इसमें हो जाएगा isovolumetric contraction. Heart is contracting in systole. Then there is rapid ejection, and then there is slow ejection. Let me draw the heart once, then we will understand. So ऐसे this is the heart, say suppose. Okay, this is right atrium, right ventricle, left atrium, left ventricle. Okay, now in between the right atrium, right ventricle, left atrium, left ventricle, there are valves, and these are known as AV valves. And then from right ventricle and left ventricle, vessels are arising. ऐसे जाती हैं vessels. Okay, इससे vessels जा रही हैं. So there are valves between these ventricles, and these are known as the semilunar valves. Now when this isovolumetric contraction is occurring, name देखो isovolume, that means volume is same, volume is not changing. तो that means blood is not moving anywhere. ठीक है, तो volume is same. And when this is happening, these valves, all the valves, AV valves, semilunar valves, everything is closed. Okay, all valves are closed. Rapid ejection, because now right ventricle, left ventricle are contracting, and pressure has developed, now the volume, blood volume is going to enter into the vessels. ठीक है, and when will that happen? That should happen when semilunar valves open. तो यहाँ पे at the end of isovolumetric contraction, remember that semilunar valves open. Semilunar valves open. Okay, rapid ejection and slow ejection, blood is moving out of the ventricles. Then diastole will start, that is relaxation of the ventricles will start. So we have first phase, that is protodiastole, that means just start of the relaxation. And after this protodiastole, this semilunar valves which have opened, they are again going to close. So semilunar valves close. Okay, and after this the phase will start, that is isovolumetric relaxation. Again no change. See, AV valves are already closed, semilunar valve also closed. After this isovolumetric relaxation, AV valves will open. ठीक है, so isovolumetric relaxation के पहले semilunar valve close, just before the beginning semilunar valve close, and after that AV valves open. And then after this we have 3 phases, that is rapid filling, then diastasis also known as slow filling, and then we have second rapid filling phase, or what is due to atrial contraction. ठीक, अब इन phases के बाद let us discuss some quick very important points that why is this happening. पहला तो देखो, after second rapid filling what will happen, the AV valves will close again. ठीक है, AV valves will close. So again this phases of systole will start. So isovolumetric contraction, before isovolumetric contraction AV valves close, at end of isovolumetric contraction semilunar valve open. During the phase all the valves are closed, and that is why volume is not changing. Okay, isovolumetric relaxation, before that semilunar valve close and AV valves open at the end. ठीक, so this opening and closing of valves you have to remember when it is opening and closing. Isovolumetric contraction, AV valves close before it and semilunar valves open after it. So that is one thing, that opening and closing of the valves you should remember. Then these valves closure causes sounds. Okay, so this AV valve closure, it causes sound, that is S1, that is first heart sound. On the other hand this semilunar valve closure causes second heart sound. ठीक है, तो कह सकते हैं that end of systole second heart sound is occurring, end of diastole first heart sound. और देखो language it will change, beginning of systole, before that first heart sound is occurring, end of systole second heart sound is occurring. So in this diagram also we can mark, देखो S1 S2. ठीक है, end of systole second heart sound is occurring. Then there is third heart sound also, that is due to rapid filling of the ventricles, that is third heart sound. And fourth heart sound is in the atrial contraction. ठीक है, so this is fourth heart sound. Done. So this is all about the cardiac cycle. And then in this cardiac cycle, now questions are being asked upon the PV loop also, pressure volume loop in the heart. So bilkul this we will represent in the pressure volume loop. Okay, so this is the volume, this is the pressure. So this is initially there is increase in the volume, so we'll write AB. Then now what is happening? Pressure is increasing. This is a straight line. Okay, pressure is increasing, volume is not changing. Uske baad we'll draw like this, and then we'll draw like this. So what is this? See, we'll just mark it. So यहाँ पे volume is increasing. So this is ventricular pressure volume. याद रखना that it is happening in ventricle. You will be able to correlate. So ventricle volume is increasing, ventricle filling is occurring. That means this is ventricular filling phase. Then here pressure is increasing, volume is not changing. So volume is not changing, it means it is isovolumetric phase, but pressure is increasing, so this is phase of isovolumetric contraction. यहाँ पे volume is decreasing. देखो ऐसे arrows you have to draw. ठीक है, तो यहाँ से यहाँ जा रहा है यानी volume is increasing, यहाँ से D की तरफ जा रहा है तो यानी volume is decreasing. So this is the phase of rapid ejection. Blood is moving from ventricles to the aorta or the pulmonary vessels, and again here it is pressure is decreasing, so this is phase of isovolumetric relaxation. Now in this, if I mark where the sounds are occurring, see after isovolumetric contraction, here semilunar valves will open, then only the ejection will start. So semilunar valves open here, and before isovolumetric contraction AV valves are closing, AV valves close. ठीक है? And here what is happening? This is semilunar valves close after ejection and here AV valves open. ठीक है? सिंपल याद रखो, नीचे में AV valves पहले open then AV valves close, up semilunar valves open, semilunar valve close, AV valves open, AV valves close, semilunar valves open, semilunar valve close. ठीक है? तो semilunar valve close, isovolumetric relaxation. ठीक है? ओके डन. नाउ देखो एक प्रेशर भी है इसमें, याद रखो कि ये मैक्सिमम प्रेशर इज 120 मिलीमीटर मर्करी और यहाँ पे when it is 80 millimeter mercury, that time semilunar valves are going to close. ये aorta के pressures हैं. So when we talk about aorta, then there is one pulse tracing also which you should know. ऐसी pulse tracing होगी, ठीक है? So this is the pulse tracing in the large vessels or aorta. और उसमें what is this point? This is dicrotic notch. देखो when systole is started then the pulse pressure it is going to increase, pressure is going to increase. फिर यहाँ पे diastole has started और relaxation start हुआ है and then it is going like this, but in between there is one interruption, there is this increase in the pressure and that is known as dicrotic notch. That happens because of closure of aortic valve. क्योंकि हम एओर्टा का प्रेशर देख रहे हैं, दैट इज व्हाई वी आर कॉलिंग इट एओर्टिक वाल्व, नॉट सेमिलुनर वाल्व. क्लोजर ऑफ एओर्टिक वाल्व. ठीक है? सेमिलुनर वाल्व व्हेन वी से देन इट इज फॉर बोथ पल्मोनरी वाल्व एंड एओर्टिक वाल्व. सो डाइक्रोटिक नॉच इज ड्यू टू क्लोजर ऑफ एओर्टिक वाल्व. सो दिस वाज ऑल अबाउट द कार्डियक साइकिल. नेक्स्ट इज जेवीपी, वेरी इंपॉर्टेंट टॉपिक. JVP में there are 5 waves which you should remember. They will tell you the mnemonic also. So what are these waves? A wave, C wave, X wave, V wave और Y wave. A, C, V, these are positive waves. देखो ये ऊपर जा रहा है, ठीक है? When it is increasing, A, C, V are positive waves, X and Y are negative waves. A wave occurs due to A for atrial contraction, A wave, ठीक है? Atrial contraction. C is occurring due to tricuspid, मैं इसका C याद रखती हूँ, tricuspid bulge. और tricuspid bulge it happens in isovolumetric contraction phase. X phase, downward phase is due to atrial relaxation, इसका X, okay? V phase is due to venous filling in the atria, V for venous filling in atria. And Y wave is due to atrial emptying में Y आता है तो atrial emptying, और we can say it is also ventricular filling. atrial empty होके तो ventricular fill हो रहा है ना, तो atrial emptying या फिर we can say ventricular filling. For remembering I remember atrial emptying. ठीक, तो ये हमारा हो गया. Next moving on to another important topic, that is blood pressure. तो blood pressure में से there are sensor for detecting blood pressure. We have this carotid sinus and यहाँ से common carotid artery and then divides into internal carotid and external carotid artery. और there are receptors. Where are they? They are in aortic sinus. Also the name is like that, aortic sinus or carotid sinus. Carotid sinus basically just after the bifurcation in the internal carotid artery, carotid sinus. तो ये तुम्हारे receptors हो गए. Now information from carotid sinus goes via 9th nerve. Information from aortic sinus goes from 10th nerve. इसके बीच में भी there are small nerves. These are known as Herring's nerve. So the information is going to the 9th nerve. Then from 10th nerve, both of these nerves go to medulla. ठीक है? तो medulla में there is a center known as nucleus tractus solitarius. From there it goes to another center, that is CVLM, caudal ventrolateral medulla. Caudal means below. ठीक है? Then from here it goes to RVLM, पर ये देखो यहाँ inhibit करता है RVLM. Then from RVLM it goes to spinal cord और फिर वहां पे बेसिकली स्पाइनल कॉर्ड को हटा के डायरेक्ट सिंपैथेटिक सिस्टम एक्टिवेशन. ठीक है? और यहाँ से एक तुम्हारा जाता है वेगस को भी. ओके, तो अभी इसको वी विल मेक सेंस हाउ इट इज. सी व्हेन ब्लड प्रेशर इंक्रीजेस Then more information is going to nucleus tractus solitarius. Then from there information is going to CVLM, and that is going to inhibit RVLM, which is causing excitation of sympathetic. तो अभी क्या है कि ये inhibit हो जाएगा RVLM. जब BP बढ़ेगा then RVLM will be inhibit. So sympathetic supply is going to decrease. Sympathetic system करता क्या है? Sympathetic system it supplies the heart and vessels. कौन सी vessels? Arterioles and veins. ठीक है. हार्ट में इट इंक्रीजेस हार्ट रेट एंड स्ट्रोक वॉल्यूम, आर्टीरियोल्स में वेजोकॉन्स्ट्रिक्शन, वेन में वीनोकॉन्स्ट्रिक्शन. तो व्हेन सिंपैथेटिक सिस्टम इज मोर एक्टिव देन यहाँ पे कॉन्स्ट्रिक्शन होगा, पेरिफेरल वस्कुलर रेजिस्टेंस इट विल इंक्रीज, टोटल रेजिस्टेंस बढ़ जाएगा. एंड पेरिफेरल वस्कुलर रेजिस्टेंस डायरेक्टली रिलेटेड है डायस्टोलिक ब्लड प्रेशर से. याद रखो व्हाट इज द डिटर्मिनेंट ऑफ डायस्टोलिक ब्लड प्रेशर? पेरिफेरल वस्कुलर रेजिस्टेंस. तो आर्टीरियोल्स व्हेन दे कॉन्स्ट्रिक्ट, पेरिफेरल वस्कुलर रेजिस्टेंस इंक्रीजेस, डायस्टोलिक ब्लड प्रेशर increases. Veins when they constrict there is increase in the venous return to the heart. तो जब venous return increase होगा तो cardiac output increase होगा. इसको क्या कहते हैं? इसको कहते हैं Frank-Starling's law. Frank-Starling's law. ठीक है? That when venous return increases cardiac output increases. Simple terms we say that how do we define the law? Cardiac output or strength of contraction is directly proportional to initial length of the muscle. याद रखना, strength of contraction is directly proportional to initial length of the muscle. When venous return increases, initial length of the muscle increases, stretching होता है, तो उससे cardiac output increase होता है because strength of contraction increases. ठीक है. तो we were back to sympathetic system. Sympathetic system क्या करेगा? It will all this is going to increase the cardiac output, increase the peripheral resistance. Because of this there will be increase in the blood pressure. अभी तुम्हारा blood pressure जब it has already increased तो RVLM is inhibited. Because of that sympathetic supply decreases and hence BP decreases. तो ये क्या है? This is what? This is negative feedback. ठीक है? This is negative feedback. Okay. So this is the BP reflex. Now because of this there is a reflex which you should know, that is law. Actually this is Mary's law. According to Mary's law, when BP increases heart rate decreases. ऐसे सेंटेंस में बोले तो हार्ट रेट इज इनवर्सली प्रोपोर्शनल टू बीपी. व्हेनेवर बीपी इंक्रीजेस हार्ट रेट डिक्रीजेस, व्हेनेवर बीपी डिक्रीजेस हार्ट रेट इंक्रीजेस. वो इसी की वजह से बिकॉज ऑफ दिस बैरो रिफ्लेक्सी इंक्रीज बीपी, सिंपैथेटिक सिस्टम डिक्रीजेस, सो हार्ट एक्टिविटी इज डिक्रीजिंग, सो हार्ट रेट इज डिक्रीजिंग एंड बिकॉज ऑफ दिस बीपी इज करेक्टेड. ओके. तो मैरीज लॉ सिंपल याद रखो, इंक्रीज इन बीपी डिक्रीज हार्ट रेट. बट मैरीज लॉ को उल्टा नहीं बोल सकते दैट हार्ट रेट इंक्रीजेस बीपी डिक्रीजेस. नो, वी डोंट से like that. Increase in BP causes decrease in the heart rate. ठीक? So that is Mary's law. Then there are certain other reflexes which we should remember, that is Bainbridge reflex. Bainbridge reflex says that when heart rate increases, when venous return increases then there is increase in the heart rate. तो सिंपल है ये देखो, इफ इनकमिंग इज इंक्रीजिंग, वीनस रिटर्न इज इंक्रीजिंग, देन आउटगोइंग शुड इंक्रीज. और वो कैसे होगा? बाय इंक्रीजिंग द हार्ट रेट. सो व्हेन वीनस रिटर्न इंक्रीजेस, इंक्रीज इन द हार्ट रेट. दूसरा वी डिस्कस्ड अबाउट फ्रैंक स्टार्लिंग, वो इसमें है इंक्रीज इन वीनस रिटर्न कॉजेज इंक्रीज इन स्ट्रेंथ ऑफ कॉन्ट्रैक्शन. ठीक है, दोनों से कार्डियक आउटपुट इज इंक्रीजिंग. So this part, increase in venous return causing increase in strength of contraction, this is Frank-Starling law. Increase in venous return causing increase in heart rate, that is Bainbridge reflex. Okay. Then we have other reflex, that is Cushing's reflex. What is Cushing's reflex? Cushing's reflex is that if there is increase in intracranial pressure, this leads to decrease in heart rate, that is bradycardia. Actually increase in intracranial pressure and because of this increase in blood pressure and because of this there is decrease in the heart rate. ऐसे है, but इसको याद रखो, increase in intracranial pressure, decrease in the heart rate. तीसरा reflex is Bezold-Zarisch reflex. Bezold-Zarisch reflex. Bezold-Zarisch reflex says if we inject some chemical like serotonin, capsaicin in the coronary vessels, then there is a response. क्या response होगा? There will be decrease in the respiratory rate, decrease in the heart rate, decrease in the blood pressure. ठीक, सब कुछ decrease है. इसको कहेंगे apnea. stoppage of respiration हो जाएगा actually. So apnea, bradycardia and hypotension that occurs due to dissolved Zarish reflex. ठीक है. Then what is the next topic in cardiovascular system? Very important, that is hemodynamics. ठीक है. Hemodynamics, main thing which we will remember is Poiseuille's law, according to which flow is equal to delta P by R. Delta P is the pressure gradient divided by R, that is the resistance. So flow is equal to delta P by R. अभी R को expand करेंगे, resistance कौन से factors affect the resistance, that we will write delta P divided by, ऐसे लिखते हैं. तो ये सब factors we will not remember, we will simply remember it like that. Okay, and L. So this is flow. So what is this? This is radius, this is viscosity, and this is the length of the vessel. तो flow जो है directly proportional है R to the power of 4, right? तो suppose if radius is doubled, अगर radius पहले 1 था, now if radius of the vessel increases to 2, तो flow will increase how much? R to the power 4. तो simply you do 2 into 2 into 2 into 2. So because R to the power 4, right? So कितना आ जाएगा? 16 times. ठीक है. अगर इसको radius is suppose 4 times it becomes, then तुम्हारा 3 times भी आ चुका है, 2 times भी आ चुका है, maybe 4 times will also come. So you should know how to do. 4 times है तो 4 into 4 into 4 into 4, right? So it will increase to 56 times. Done. So similarly viscosity का भी it can come because radius is being asked, so viscosity can be asked. तो अगर viscosity देखो बढ़ेगी तो फ्लो कम होगा, विस्कोसिटी अगर डबल हो जाती है तो फ्लो विल बी हाफ्ड. Fine. So this is hemodynamics, important thing. Then 1 or 2 points about coronary circulation and cerebral circulation you remember. पहला, coronary circulation in maximum is in diastole. Maximum it is in diastole. ठीक है. तो जब heart is relaxing, that time coronary circulation happens. And one thing about cerebral circulation is directly proportional to partial pressure of carbon dioxide in the circulation. So if partial pressure of carbon dioxide increases, cerebral circulation is going to increase. Partial pressure of carbon dioxide doubled, cerebral circulation is going to double. ठीक है. So we have completed respiratory system, we have completed cardiovascular system. Now moving on to the central nervous system. Okay, so central nervous system we will talk now. ठीक. So in central nervous system again we will discuss all high topics. First is what is receptors, what are the various important receptors. तो इसमें most important very commonly asked is receptors for vibration. So we have Pacinian corpuscle. ठीक है. अच्छा, we'll write it different way. We'll write the sense first. So when it is vibration, two things you remember: low frequency vibration, low frequency, and high frequency. High frequency or fast vibration. So low frequency vibration, Meissner's corpuscle, and high frequency vibration, Pacinian corpuscle. Pacinian corpuscle is very, very important, most important receptor for vibration. Then we have another sensation, 2-point discrimination. That is ability to tell 2 points as separate. ठीक है, जैसे ऐसे छू रहे हैं तो 2 points are separate. So that is 2-point discrimination. This is done by Merkel cells. ठीक. And that is why 2-point discrimination, it is important for reading Braille. Okay. So blind individuals, they touch the script and read. Okay, so for that 2-point discrimination is important. So that is Merkel cells. Then next is sustained touch. Sustained touch is by Ruffini index. So this is all important. Okay. Then we have pain receptors, pain and thermal receptors, that is free nerve endings. Pain and thermal sensation, free nerve ending. ठीक है. Now these receptors are present all over the skin. From there some neurons are arising. These are the afferents. So what are the afferents that we will see? So we have different fibers: A alpha fibers, A beta, A gamma, A delta, B and C fiber. So this is all A, B, C. So A alpha, this is a motor neuron. A alpha motor neuron is, A alpha neuron supplies the skeletal muscle. So in sensory, it is not needed. A gamma, gamma motor neuron, again, gamma motor. Okay. So A alpha, A gamma are motor. What is important in sensory is A beta, A delta, and C fibers. So A beta, ta for touch. Okay. A beta is for touch. A alpha also, it is for proprioception. Important. Okay. A alpha is for proprioception, pressure also. PP. A beta for touch. Okay. A delta for that is cold. Okay. Yeah. Then C fiber is just for hot. Okay. Then A delta, it is also for A delta and C also for pain. A delta for fast pain and C fibers for slow pain. Okay. How I remember? See, when we feel hot in mouth, no, we do like that. So that is C fiber, and A delta here cold. So that is A delta is for cold, right? And C fiber, it is slow pain. C slow pronunciation, it is slow pain. A delta fast pain. Now what is the difference between these fibers? See, these fibers, as we move from A to B to C, diameter of these fibers is decreasing. Diameter decreases. Velocity also decreases, diameter decreases, velocity decreases, and myelination also decreases. A fibers are highly myelinated, B fibers are lightly myelinated, and C fibers are unmyelinated. Okay? So this is fundamental, you should remember, many questions come from this. So I gave you mnemonics also. Then moving on to the tracts. What are the tracts we are talking about? We are talking about ascending tracts and descending tracts. When we talk about ascending tracts, ascending means they are for sensory information. So we will mainly here discuss ascending. In motor system, we will talk about descending tracts. So ascending and descending. Descending is for motor. Ascending tracts, again we have two types, main two types of tracts we have. That is anterolateral spinothalamic tract, anterolateral spinothalamic tract, and we have posterior spinothalamic tract, also known as dorsal column. Anterolateral spinothalamic tract, again it's divided into two. Basically it is starting and then it is traveling in the spinal cord as two different tracts, that is anterior and lateral. So anterolateral, so anterior and lateral. Lateral, it is the sensation which it is carrying is pain and temperature, and anterior, the sensations which it is carrying is crude touch, okay, itch and sexual sensations. Then dorsal column, all other sensations are carried by dorsal column. These are advanced sensations. So these include dorsal column. What are the sensations? Vibration, proprioception, pressure, 2-point discrimination, stereognosis, okay, and this graphesthesia, all basically others that is carried by dorsal column. So this is about the ascending tracts, and in this you remember some point about pain, that question is asked about hyperalgesia and allodynia. Hyperalgesia and allodynia. What is this? Hyperalgesia is that when with a little bit stimulus, mild stimulus, we feel excessive pain. So hyperalgesia, excessive pain with mild stimulus which can cause pain. तो उसको कहते हैं noxious stimulus. Mild noxious stimulus causes too much pain. Allodynia, non-noxious stimulus. That means like a touch stimulus. Touch stimulus normally doesn't cause pain. So when a touch stimulus causes pain, that is known as allodynia. Okay, so this is about sensory system. Moving on to the motor system, so that we will talk, that is what is descending tracts. Okay, no, first we will discuss about the stretch reflex. Okay, so first we will discuss about the stretch reflex and inverse stretch reflex. So this is the muscle, right? This is the muscle. And inside muscle we have sensory fibers as well. So that is known as intrafusal fibers. Okay, so this is intrafusal fiber and this is extrafusal fiber. So what is the nerve supply? Extrafusal fiber is supplied by alpha motor neuron, and intrafusal fiber, it is sensory. Remember, intrafusal fiber is sensory and ends of intrafusal fibers are supplied by gamma motor neuron. Mostly it is sensory except the contractile ends. Okay, so alpha motor neuron supplies the extrafusal fibers which contract, and intrafusal fiber contractile ends are supplied by the gamma motor neuron. Okay, now this intrafusal fiber, it is sensory, I told you. So sensory means it detects what sensation? It detects the length of the muscle and it detects the velocity of change in the length. ठीक है, मतलब length इस समय हमारी length, what is the length here? What is the length here? Velocity of change, मतलब from here to here, how it has gone? It has gone like this, fast, or it has gone slowly. So that velocity also it will detect. Okay, length and velocity, and it is also the receptor for proprioception. ठीक है, proprioception. So we will know the position of the body. So that is this intrafusal fiber, or what is known as muscle spindle. Muscle spindle. Okay. Now what is the afferent here? Afferent is 1A and 2 fibers. 1A and 2 fibers, and here it is going into the spinal cord. So suppose this is the spinal cord. Okay, and it goes to the spinal cord and synapses with the alpha motor neuron. So let me draw another color. So this is alpha motor neuron, it synapses with this, and this alpha motor neuron, I told you, it is supplying the extrafusal fiber. Okay, so stretch reflex, when there is increase in the length of the muscle, there is increase in the afferents in 1A fiber or 2 fiber, then it causes excitation of the alpha motor neuron. So this is excitatory here, and this is leading to muscle contraction, because alpha motor neuron will lead to muscle contraction. This is stretch reflex. ठीक. Then coming to inverse stretch reflex. What is inverse stretch reflex? Here in the muscle tendon, there is another sensory organ, that is Golgi tendon organ. Golgi tendon organ. And Golgi tendon organ, from here the impulse is carried by 1B fibers, and it goes enter into the spinal cord like this. Okay, enter, and then via an interneuron. It inhibits this alpha motor neuron. Inhibits. Okay. So Golgi tendon organ, what does it sense? It senses the tension in the muscle. Okay, we'll write here. Golgi tendon organ senses the tension in the muscle. When tension is too much, then this excitation of 1B fibers will be too much, and via an interneuron, it is going to inhibit alpha motor neuron. Okay? Inhibit alpha motor neuron, and this is going to cause the relaxation of the muscle. Relaxation of muscle. ठीक है, so याद रखना, Golgi tendon organ is inhibitory to alpha motor neuron. Stretch reflex, 1A and 2 fibers, they are excitatory, and this is the only example. This stretch reflex is an only example of monosynaptic reflex. Monosynaptic reflex. ठीक है, so this Golgi tendon organ, this is this reflex, it is known as inverse stretch reflex. ठीक है, stretch reflex and inverse stretch reflex. Then muscle spindle, intrafusal fibers for detecting the length and velocity, and Golgi tendon organ for detecting the tension. So let us move on to the next part, that is the descending tracts. So in descending tracts, we have 2 types. Descending, जैसे ascending tracts 2 types, descending tracts also 2 types. Descending tracts, we have pyramidal tracts, and we have extrapyramidal tracts. Pyramidal tract is also known as corticospinal tract. Corticospinal tract, or along this pyramidal tract with one extrapyramidal tract. What are the extrapyramidal tract? First we will see that there is rubrospinal tract, tectospinal tract, then vestibulospinal tract, and reticulospinal tract. ऐसे लिखा है to differentiate. Okay, rubrospinal, tectospinal, vestibulospinal, and reticulospinal tract. So this pyramidal tract, that is corticospinal tract, along with the rubrospinal tract, it is important for fine control of movement. Fine control माने बहुत छोटा छोटा movement is there, small movement like writing. Okay, so that is fine control of movement. Extrapyramidal tract, all others are for gross motor movement. Gross motor movement. ठीक, so that is extrapyramidal tract. अब इसमें भी reticulospinal tract, it is further divided into medullary reticulospinal tract and pontine reticulospinal tract. Medullary and pontine reticulospinal tract. अब इसमें कुछ information is there. Vestibulospinal tract, it is excitatory to alpha motor neuron. ठीक. Reticulospinal tract, this pontine part, pontine reticulospinal tract, it is excitatory to gamma motor neuron, and this medullary reticulospinal tract is inhibitory to gamma motor neuron. ठीक, तो ये by exciting and inhibiting these neurons, it can change the tone and posture also. So it controls the tone and posture and gross motor movements. ठीक है. By the way, what is tone? Tone is the resistance offered by the muscle to passive movement. ठीक है. Suppose somebody holds my hand and causes the passive movement, there is some resistance. ऐसे sloppy नहीं है muscle, so that is known as tone. Resistance offered by the muscle to passive stretch, to passive movement, that is known as tone. ठीक है. Now moving on to some applied aspects, that is what is upper motor neuron lesion, lower motor neuron lesion, and Brown-Sequard syndrome. ठीक है. तो पहले देख लेते हैं व्हाट इज यूएमएन एंड एलएमएन लीजन. ठीक है. तो यूएमएन एलएमएन लीजन, व्हेन corticospinal tract is injured, we get both UMN and LMN features which we get. UMN features याद रखो, there is rigidity, increase in the tone, it is rigidity, sorry, when UMN is due to the injury of corticospinal tract. First is corticospinal tract. Okay, so if it is injury to corticospinal tract, it leads to spasticity, and if it is injury to extrapyramidal tract, then it is rigidity. Lower motor neuron, there is decrease in the tone or loss of tone or hypotonia. This is hypertonia. Increase in the tone is hypertonia. Another feature of upper motor neuron lesion is exaggerated tendon reflex. Exaggerated reflex. Tendon reflex क्या है? That is the stretch reflex which we discussed. ठीक है. Exaggerated reflexes, deep tendon reflexes, जो तुम्हारा knee jerk हो गया, ankle jerk हो गया. So these are all deep tendon reflexes which exaggerate in upper motor neuron lesion. And lower motor neuron lesion, there is decrease in deep tendon reflexes or loss also, loss of DTRs. Then in upper motor neuron lesion, remember positive Babinski sign. Positive Babinski sign. इसमें, if this is the sole, we strike the sole like this and move to the great toe. Like this we strike and move to the great toe, and normally there is flexion. But in Babinski sign, when there is upper motor neuron lesion, then there is extension. Okay, extension of dorsiflexion actually in all the toes, right? In lower motor neuron lesion, remember there is fibrillation or fasciculation. Fibrillation or fasciculation. ठीक है. So this is about upper motor neuron and lower motor neuron lesion. दोनों upper motor neuron and lower motor neuron lesion, there will be decrease in the power of the muscle. That is active contraction. No, that will be weak. That is power of the muscle. Tone will be more in upper motor neuron lesion. Exaggerated DTRs in upper motor neuron lesion, and the Babinski sign positive in upper motor neuron lesion. अब we will talk about Brown-Sequard syndrome. ठीक है. Brown-Sequard syndrome, ये क्या होता है? Brown-Sequard syndrome is that hemisection of the spinal cord. So let us draw one spinal cord. Okay, this is the spinal cord. अभी इसमें we will draw gray matter also. Gray matter. So this is the gray matter of the spinal cord. ठीक है. So now we have talked about ascending tracts and descending tracts. In ascending tracts, here it is the dorsal column which is carried, and anterolateral column is here. Okay. अच्छा, अब देखो इसमें थोड़ा सा, that dorsal column, it enters like this and passes like this. Okay. Anterolateral column, it enters like this, synapses here, and crosses to opposite side and climbs like this. ठीक. Then तुम्हारा descending tract है. Descending tract कैसे आता है? Descending tract is, it is coming from, say suppose this side. Okay, it has already crossed in medulla. Descending tract crosses, corticospinal tract crosses in lower part of the medulla, actually at the junction between the spinal cord and medulla. Descending tract ऊपर से आता है, it comes and goes below as much as possible in the medulla, and there it crosses. Okay, तो यहाँ से जो descending tract which is coming, it goes here, synapses here, and then there is alpha motor neuron. तो if there is hemisection of the cord, तो यहाँ पे say suppose injury is this side of the cord, that is the hemisection, what will be the features? See, dorsal column is affected, this dorsal column is affected, okay, same side, okay, so we get dorsal column features on the same side, that is loss of proprioception, vibration, 2-point discrimination on the same side of the lesion. Then देखो ये pyramidal tract also is same side, okay, so paralysis also same side, क्योंकि वहां से आया है, क्रॉस ऊपर कर चुका है, it is coming and it is supplying the same side muscles, so paralysis of same side. And here also you see that this anterolateral has crossed, तो इस side कौन से होगा fibers? It is from the opposite side, the fibers which are coming, they have crossed and come to the other side. So here we will see pain and temperature loss, anterolateral signs on the opposite side. ठीक है, simple terms, dorsal column same side, anterolateral opposite side, that is pain and temperature loss on the opposite side, paralysis same side. Okay, so this is Brown-Sequard syndrome. Okay, so moving to basal ganglia. Basal ganglia में what are the nuclei in the basal ganglia and what are the lesions which cause the various problems? So we have caudate nucleus, putamen is there, caudate nucleus, putamen. Then we have globus pallidus. Then there is subthalamic nucleus, and we have substantia nigra. ठीक है, substantia nigra lesion. What it does? Substantia nigra lesion. It is dopamine release will be less, so that will cause Parkinsonism. Caudate nucleus, it will lead to chorea. ठीक. Then subthalamic nucleus, it will lead to hemibalismus. अगर ये डैमेज होगा hemibalismus, ठीक है. और globus pallidus damage, it will lead to athetosis. ठीक है. Caudate nucleus CC याद करना आसान है. Caudate nucleus chorea. Athetosis is dancing movements. Okay. Hemibalismus sudden violent movements of the whole limb. So यहाँ से start होगा and there will be hemibalismus, sudden violent movement. Parkinsonism के features also important. What are the features? It leads to rigidity. It leads to resting tremors. Okay. Rigidity, resting tremors, or hypo movement is there. Bradykinesia will be there. Slowness of the movement. Okay. Akinesia, that is total stoppage of the movement. Start ही नहीं होगा movement, that is akinesia and bradykinesia. So resting tremors happen in Parkinsonism, and intention tremors, that is when the movement is occurring, when the person is going to pick up something, say something, then that intention tremors will be seen. So that is basal ganglia. चलो, moving on to higher functions. में first is EG. ठीक है. EG 4 waves you remember. अच्छा, sequence what to remember is BAT-D. Beta, alpha, theta, delta. Beta highest frequency, delta lowest frequency. ठीक है. और frequency keeps on decreasing. तो highest frequency कितनी है बीटा की? It will be 13 to 30 hertz. Alpha, it is 8 to 13 hertz. Theta, it is 4 to 8 hertz, 4 to 7 hertz. Okay, and less than 4 hertz it's delta. So beta, when does it occur? That occurs when mind is active, okay, awake and focused state. That is beta. Alpha, awake but wandering, mind is just wandering, you are not paying attention. Okay, so abhi what is the wave in your brain depending on whether you are focused or wandering? So awake and wandering is alpha. Theta waves is light sleep and also in children, and delta waves is during deep sleep. Okay, then areas in the brain also important. Beta waves mainly in parietal and frontal region, alpha waves in occipital region, थीटा वेव्स इन पैराइटल एंड टेम्पोरल रीजन। तो इतना याद रखना है फॉर द ईजी वेव्स। अच्छा, आई टोल्ड यू दैट फ्रॉम बैड टू डीप फ्रीक्वेंसी इज डिक्रीजिंग एंड एम्पलीट्यूड ऑफ द वेव्स इज इंक्रीजिंग। तो मैक्सिमम एम्पलीट्यूड कौन सी वेव का होगा? इट इज द डेल्टा वेव। लीस्ट मैग्नीट्यूड कौन सी वेव का होगा? इट विल बी द बीटा वेव। सो दैट इज अबाउट द ईजी वेव्स। देन द sleep we have two types, okay, that is NREM and REM. तो फ्रॉम वेकफुलनेस व्हेन वी आर स्लीपिंग वी गो इनटू एनआरईएम स्लीप। और कौन सी स्लीप में? वी गो इनटू स्टेज 1। तो एनआरईएम में भी 4 स्टेजेस होते हैं, एनआरईएम 1, 2, 3, 4। आरईएम इज आफ्टर एनआरईएम 4 देयर विल बी रेम स्लीप। तो इन एनआरईएम what are the characteristics basically? So EEG also varies. In NREM 1 and 2 there will be light sleep, so that is theta waves will be there. And in stage 2 we have spindles also. This K complexes are there. These are biphasic waves and sleep spindles. Okay, K complexes, high voltage waves, sleep spindles also there. 3 and 4 we have deep sleep, so that is delta waves will be seen. ठीक। REM sleep, rapid eye movement sleep. REM sleep is also known as rapid eye movement sleep or also known as paradoxical sleep. And in this we will see beta like activity. तो ऐसा लगता है कि person is awake if we see the EEG, but it is beta like activity and it appears like sawtooth waves. Okay, also seen are PGO spikes. ठीक है, तो याद रखने की वाली बात है। स्टेज 2 में के कॉम्प्लेक्सेस, स्लीप स्पिंडल्स, रेम आल्सो नोन एज पैराडॉक्सिकल स्लीप, और बीटा लाइक एक्टिविटी वी सी इन दिस, राइट। अच्छा, देन व्हाट आर सर्टेन कैरेक्टरिस्टिक? एनआरईएम स्लीप में जो है ड्रीम्स आर देयर व्हिच आर नॉट रिमेम्बर्ड, ड्रीम्स नॉट रिमेम्बर्ड, ओके, तो नॉट रिमेम्बर्ड, ठीक है। रेम स्लीप में ड्रीम्स आर रिमेम्बर्ड, तो that is one. And REM sleep में there is irregular respiratory rate, irregular heart rate, irregular blood pressure, ठीक है। And dreams in REM sleep are remembered and more emotional and visual, right? So that is about sleep. और इसमें कुछ न्यूक्लियस भी याद रखने हैं, that which are the nuclei which are responsible for wakefulness, NREM and REM. REM, remember that it is acetylcholine is high and it is the TMN nucleus, tuberomammillary nucleus. नहीं, TMN नहीं है, sorry, it is PPN nucleus, pedunculopontine nucleus. Acetylcholine is high. NREM is due to a center VLPO, ventrolateral preoptic nucleus in hypothalamus, and this is the GABA. It releases GABA. GABA is very high in NREM. फिर awake state में we have different neurotransmitters. We have brainstem nuclei and we have hypothalamic nuclei. Brainstem nuclei दो हैं, that is locus coeruleus and raphe nucleus. Locus coeruleus releases norepinephrine and raphe nucleus releases serotonin. तो both are high in awake state. Norepinephrine भी ज्यादा होता है, serotonin भी ज्यादा है। Hypothalamus में tuberomammillary nucleus releases histamine, तो histamine is high, ठीक है। And we have lateral hypothalamus which is releases orexin. तो this all is high. इसमें एक important चीज याद रखो that in narcolepsy this orexinergic neurons decrease. तो ये एक problem हो जाता है, ठीक है। narcolepsy में the person enters from wakefulness directly to REM sleep. Normally in our sleep we go from wakefulness to NREM sleep to REM sleep. narcolepsy में from wakefulness directly we go into REM sleep, ठीक। So this is about sleep. And now moving on to the next part, that is hypothalamus. So there are certain centers which you should remember in hypothalamus. What are these? Some nuclei you should remember. So this is suprachiasmatic nuclei. Suprachiasmatic nucleus is for circadian rhythm, okay, that is for circadian rhythm. Then we have this lateral nucleus, that is for hunger, thirst, also for rage, basic instincts, no? Hunger, thirst, rage, that is the lateral nucleus. Then we have ventromedial nucleus. Ventromedial nucleus is the satiety center. That means now stop eating. That is given by ventromedial nucleus. Then we have supraoptic nuclei and the paraventricular nuclei. Paraventricular nuclei for release of oxytocin, supraventricular nuclei for release of vasopressin. Okay, कैसे याद रखना है? लेटरल न्यूक्लियस बेसिक जो इंस्टिंक्ट्स हैं तुम्हारा हंगर थर्स्ट रेज उसमें है. पैरावेंट्रिकुलर न्यूक्लिया आई रिमेंबर ओपी. ठीक है. देन एस एंड वी आर आल्सो क्लोजर. सो सुप्राऑप्टिक पैरावेंट्रिकुलर, डोंट गेट कंफ्यूज दैट व्हिच इज रिलीजिंग व्हाट. सुप्राऑप्टिक vasopressin, paraventricular nucleus oxytocin. Then we have osmoreceptors. We also have anterior nuclei. Anterior nuclei, they are present in osmoreceptors. तो इसमें one thing I want you to remember that when there is increase in the osmolarity, there is a stimulation of these osmoreceptors which are present in this anterior nuclei, and this stimulates this centers. Which centers? Osmoreceptors अगर stimulate होंगे, then this supraoptic nuclei is stimulated for release of vasopressin, and also this lateral nucleus is stimulated for thirst. ठीक है. So osmoreceptors in anterior nuclei, then supraoptic, then this lateral nucleus. Fine. फिर उसके बाद is reward center. Which is reward center? अच्छा, reward center यहाँ पे, right. Reward center is ventral tegmental area and also the medial forebrain bundle. Medial forebrain bundle. तो rage, lateral nucleus, ventral tegmental area and medial forebrain bundle, reward center. ठीक. So this is all about certain centers which you should remember. Then going to the last part, that is the speech. ठीक है. Speech, what is important? Speech, we should remember some centers in speech, that is Broca's area and Wernicke's area. Broca's area is the motor center, motor area for speech. So it is important for production of the speech. ठीक है. तो जो हम we are moving all the muscles, no? So that command comes from Broca's area. So that is the motor area. Wernicke's area is the sensory area for speech, and it is for understanding of the speech. ठीक है. Understanding of the speech. Broca's area and motor area. Now these areas, Broca's area and Wernicke's area, are connected by arcuate fasciculus. ठीक है. अच्छा, Broca's area, if that is damaged, it will lead to motor aphasia. That because it is a motor area, no, it is going to lead to motor aphasia. That means the person speech production will be abnormal. And Wernicke's area, if it is damaged, then it will lead to sensory aphasia or Wernicke's aphasia, and the person will not be able to understand the speech. In Broca's area, the person in motor aphasia, the person will be able to understand the speech, but the speech production will be abnormal. Okay, chalo, last system pe we will go, that is the renal system. Renal system. ठीक है. अच्छा, renal system में what is important? Renal system, first we will talk about glomerular filtration rate. So normal glomerular filtration rate is 125 ml per minute, या we can call it as 180 liters per day. ठीक है. So first we should know that how this glomerular filtration rate occurs. Basically, what are the forces? तो चलो, this is the capillary. ठीक है. This is the capillary. And here is the Bowman space. Bowman space is like this. Okay. So what are the forces which affect the glomerular filtration rate? We have the capillary hydrostatic pressure and capillary oncotic pressure. Then in the Bowman space, we have Bowman space hydrostatic pressure and Bowman space oncotic pressure. So capillary hydrostatic pressure, it is going to increase the filtration. So this promotes filtration. Hydrostatic pressure is a push force, okay, so it promotes filtration. Oncotic pressure is a pull force, so it will inhibit, that is, it will decrease the filtration. Bowman space hydrostatic pressure, it is a push force, तो ऐसे push करेगा उल्टी direction में. So Bowman space hydrostatic pressure, it will decrease filtration. एंड ऑनकोटिक प्रेशर इट इज गोइंग टू इंक्रीज फिल्ट्रेशन, क्योंकि यहाँ ऑनकोटिक प्रेशर है तो फिर इट इज गोइंग टू इंक्रीज, इट इज पुल फोर्स, so it is going to increase filtration. By the way, this moment space oncotic pressure is 0 क्योंकि proteins do not get filtered in the glomerulus. ठीक है, so these are the forces and proteins do not get filtered. Remember, we will talk about that filtration also a little bit here. But suppose if any factor is increasing this capillary hydrostatic pressure, then GFR is going to increase. So when will this capillary hydrostatic pressure increase? देखो, अगर यहाँ पे inflow बढ़ गया, inflow is more, for example ये arteriole, ये afferent arteriole dilates, तो inflow will increase, capillary hydrostatic pressure is going to increase. If there is increase in renal blood flow, then it is going to increase. But if there is efferent arteriole constriction, not dilation, constriction, ठीक है, अगर ये यहाँ constrict हो गया तो outflow will decrease. ठीक है, inflow increase या outflow decrease, then in all these cases capillary hydrostatic pressure is going to increase, it is going to promote the filtration. तो एक question इसमें है that if suppose this is the capillary, ये afferent arteriole है, ये efferent arteriole, and here the filtration is occurring, that is this is the capillary part. So what will happen to renal blood flow and the filtration if afferent arteriole dilation, afferent arteriole constriction, efferent arteriole dilation and efferent arteriole constriction? ठीक है, तो we will write two parts, renal blood flow and glomerular filtration rate. So afferent arteriole dilation, what will happen? Renal blood flow, it is going to increase, this part is getting dilated. Okay, so renal blood flow is going to increase, GFR also is going to increase because capillary hydrostatic pressure is increases. Afferent arteriole constriction, both are going to decrease. Efferent arteriole dilation, तो ये ऐसे increase हो गया dilation, तो renal blood flow increases, that is why GFR also increases. लेकिन very important is this part, efferent arteriole constriction, तो renal blood flow increases, renal blood flow decreases, okay, not increases, renal blood flow decreases. क्यों? Because of the constriction resistance is increasing, renal blood flow is decreasing, लेकिन GFR जो है, GFR is going to increase. Why? Because now the outflow has decreased. Okay, तो इसको याद रखना बहुत important है, outflow has decreased, तो capillary hydrostatic pressure has increased, but too much efferent arteriole constriction, तो renal blood flow will decrease too much, this will lead to GFR decrease. Simple रखेंगे, efferent arteriole constriction decreases renal blood flow, GFR initially increases but later on decreases. ठीक है, तो this is about the GFR. अच्छा, अब GFR को measure कैसे कर सकते हैं? How to measure GFR? That is by clearance. Okay, so that we have to measure clearance, that is the plasma concentration of the substance, urinary concentration of the substance into the urinary flow rate divided by the plasma concentration of the substance. So that is how you measure the GFR and also the renal plasma flow. And what are the substances used for GFR? We use either inulin or creatinine. ठीक है, and for renal plasma flow we use para-amino hippuric acid. Inulin is the gold standard, it gives the most accurate reading of GFR. अब इसमें इंपॉर्टेंट है रेगुलेशन ऑफ जीएफआर, कैसे? ट्यूबुलोग्लोमुलर फीडबैक, व्हाट इज दैट, व्हाट इज मैक्यूला डेंसा? क्योंकि सी इवन इफ ब्लड फ्लो इज चेंजिंग, इट इज इंपॉर्टेंट दैट जीएफआर टू द किडनीज इज मेंटेन्ड, इट इज नॉट चेंज्ड मच. लेकिन वी आर सीइंग दैट इफ कैपिलरी हाइड्रोस्टैटिक प्रेशर चेंजेस देन इट इज गोइंग टू चेंज. तो बॉडी हैज मैकेनिज्म्स टू कीप जीएफआर एज कांस्टेंट, दैट इज 125 ml per minute. So for that there is ट्यूबुलोग्लोमुलर फीडबैक. ठीक है, तो what it says is that if there is increase in the GFR, that is increase in filtration, there is increase in NaCl in the filtrate. So this NaCl is detected by macula densa cells. ये कहाँ है? macula densa cells क्या होता है? देखो, this is the glomerulus. Okay, यहाँ पे ऐसे there is PCT, loop of Henle, then this is the ascending limb of loop of Henle, and here there is distal convoluted tubule. So at the junction of this thick ascending limb of loop of Henle and distal convoluted tubule, we have macula densa. तो कहाँ है macula densa की location? That is the thick ascending limb of loop of Henle. If that is not given in the option, then the answer will be DCT. Okay, so macula densa senses this NaCl, increase in NaCl, and there is a sensor. Basically it is NKCC channel, NKCC importer, sodium potassium 2 chloride symporter is there. Okay, and this causes further two things. It causes release in adenosine, okay, causes release in the adenosine, and it causes decrease in the release of the renin. ठीक. Now renin is released from where? Renin is released from JG cells, याद रखो, ठीक है. Adenosine here is a vasoconstrictor that is different from other places. Adenosine causes afferent arteriole constriction. तो उसकी वजह से अभी हम लोग ने देखा है, afferent arteriole constricts, what will happen? GFR is going to decrease. Decrease in renin, जब renin decrease होगा तो ultimately there will be decreased production of angiotensin 2. Angiotensin 2, it is going to decrease, and this is going to lead to decrease in blood pressure. जब decrease in blood pressure होता है तो decrease renal blood flow भी हो जाता है, और decrease renal blood flow की वजह से भी यहाँ पे GFR is going to decrease. Okay, तो ये भी GFR को decrease कर देगा. So this is tuberoglomerular feedback. याद रखने वाली बात है कि macula densa cells, where it is present, thick ascending limb of loop of Henle, what is the sensor? NKCC, and what is released? Adenosine is released, and there is decrease in the release of the renin. ठीक है. Now going into each individual aspects of various parts of the tubule. So let me draw the diagram first. Say suppose this is the Bowman's capsule. Now here it is going the descending limb of loop of Henle. Then we have this loop of Henle. Okay. Then we have thin ascending limb of loop of Henle and thick ascending limb of loop of Henle. Okay. Then it goes as like this. It is distal convoluted tubule, and we have the collecting duct. Okay. So what are the important points in each? First of all, this is proximal convoluted tubule. In proximal convoluted tubule, there is maximum absorption of water, sodium. Okay, so these are like 70% reabsorbed here. Then there is a reabsorption of bicarbonate ions. Okay, maximum bicarbonate ions are absorbed here. Then we have the glucose and amino acids. They are completely reabsorbed in PCT. Very important. Okay, so this glucose and amino acids are completely reabsorbed in PCT. That is 100% reabsorption is there. So this reabsorption, glucose reabsorption, occurs because of a transporter SGLT2. Actually both are present, SGLT2 and SGLT1 both are present, but for you important to remember is SGLT2. For SGLT1, remember that it is present in the intestine, so glucose absorption in the intestine occurs via SGLT1, but glucose reabsorption in the PCT occurs via SGLT2. Okay? So this is about a proximal convoluted tubule. Then here the tonicity doesn't change. It is 300 milliosmoles. Normal tonicity of the blood is approximately 280 milliosmoles. For simplicity here we are telling 300. So it is same 280 milliosmoles or 300 milliosmoles per everywhere here in PCT. So the fluid, the filtrate here is isotonic to plasma. ठीक है. Now descending limb of loop of Henle, it is permeable to water only, not to solutes. अभी यहाँ तक हमने PCT में देखा solutes are also being reabsorbed along with water. तो फिर उसकी tonicity is not changing. Now here only water is moving out, solutes are not moving out. ठीक है. तो here the tonicity in the loop of Henle, the tonicity increases, so it becomes hypertonic. ठीक है, hypertonic. अभी here in the ascending limb, it is permeable only to solutes, and there is the symporter NKCC, sodium potassium 2 chloride symporter. ये भी symporter है, SGLT2 भी symporter है, sodium potassium 2 chloride symporter, but no permeability to water in ascending limb. Only solute is moving. तो यहाँ पे जब पहुंचेगा filtrate, because solute has gone outside, here it will become hypotonic. Here also it becomes hypotonic. Okay, so this all region is impermeable to water. ठीक है. So it becomes hypotonic. Isotonic in PCT, hypertonic in loop of Henle. Then in the ascending limb of Henle, because of NKCC, solute reabsorption, no reabsorption of water, so the fluid becomes hypotonic. Okay, so abhi we will just finish these symporters or the transporters which are present in the DCT. We have sodium chloride symporter, sodium chloride, ठीक है. And in the collecting duct we have actually these are all lined by cells, you understand that, right? So all lined by cells, and in the collecting duct we have P cells, that is the principal cells, and I cells, that is the intercalated cells, ठीक है. P cell is for potassium secretion, potassium secretion, P for potassium, and I cell, I से क्या बन जाएगा, H बन जाएगा, ठीक है. I cell is for hydrogen secretion. Okay, so and P cells have a transporter, that is ENaC, epithelial sodium channel transporter is there, ठीक. Now yeah, we were talking about first we covered PCT. Now we were talking about this ascending limb. NKCC transporter is there. It will lead to more reabsorption of sodium also. So 25% of sodium is reabsorbed here, and this NKCC is blocked by furosemide or loop diuretics, ठीक है. And it is mutated in a disease, that is Bartter syndrome. So it is not going to function in Bartter syndrome. Okay, so that is another thing. Then I told you that here at the junction thick ascending limb macula densa cells are present, and this NaCl transporter which is present in the distal convoluted tubule, it is blocked by thiazide diuretics, and it is mutated in a condition known as Gitelman syndrome. Okay, Gitelman syndrome. Then this ENaC, it is blocked by aldosterone antagonist, basically by potassium sparing diuretics, aldosterone antagonist, and by amiloride. These are potassium sparing diuretics, and overactivity of this is seen in Liddle syndrome. Overactivity is seen in Liddle syndrome, ठीक है. Plus one more thing here, very important, that this P cells and I cells, they are stimulated by aldosterone, ठीक है. So aldosterone, what it does, that it causes this ENaC stimulation will be there. Actually there is more insertion of this ENaC into this cell, so here it comes like this. So sodium reabsorption increases and potassium secretion increases. Then hydrogen secretion also increases if aldosterone is there. So aldosterone antagonist मैंने बोला ना, तो aldosterone antagonists block the action of aldosterone, जिससे कि sodium is not reabsorbed. तो aldosterone antagonists are there. तो ये याद रखना, these are potassium sparing diuretics. और क्या है इसमें, अच्छा एक चीज यहाँ पे भूल गए कि ये देखो यहाँ बताया था कि दिस इज द वाटर विच इज मूविंग आउट, तो ये हाइपरटोनिक कर रहा है फ्लूइड को, तो दैट इज व्हाई दिस इज नोन एज कॉन्सेंट्रेटिंग सेगमेंट ऑफ द नेफ्रॉन. And this thick ascending limb and the DCT, these are known as the diluting segment of the nephron. Diluting segment of the nephron. Okay. Right, so this is about the nephron parts and what is happening. Then vasopressin also you should remember, vasopressin. Vasopressin, where is it acting? Vasopressin is acting on DCT, CT and CD, distal convoluted tubule, collecting duct and connecting tubule. So vasopressin is acting there, and there is presence of V2 receptors there. This causes increase in CAMP and hence insertion of aquaporin 2 channels. तो यहाँ पे जो cells हैं इनमें aquaporin 2 channels it inserts, and because of this there is increase in water reabsorption. ठीक है, water reabsorption is caused by vasopressin. अच्छा, question comes that maximum water reabsorption occurs in presence of vasopressin. Maximum water reabsorption occurs which segment? The answer is not DCT. The answer is proximal convoluted tubule also. See, I told that 70% of water reabsorption is occurring in proximal convoluted tubule. With or without vasopressin, doesn't matter. 70% water reabsorption occurs in PCT. ठीक है, तो vasopressin is causing facultative water reabsorption. Here what is known as, this is known as obligatory water reabsorption. obligatory water reabsorption. Vasopressin, agar body needs, if body needs, then there is increase in the water reabsorption, so that is known as facultative water reabsorption. Okay, so we discussed about the various parts of the nephron, we discussed about the diuretics also and some disorders also. Acha, there is this glucose reabsorption, how that occurs, इसके बारे में little bit information you should know, that glucose reabsorption, I told you it is occurring in PCT, and what is the transporter? SGLT2, sodium glucose transporter 2 is the transporter, and there is something known as Tmax. Tmax, that is the transport maximum of glucose, that is the maximum glucose which can be absorbed in the nephrons, and that is 375 milligrams per minute. That is the maximum rate of glucose reabsorption in the nephrons. If more glucose is filtered, then that glucose is not going to be reabsorbed. लेकिन इसमें भी actually ये जो है 375 milligram per minute ये होएगा when we have plasma concentration of glucose, if we have the plasma concentration as 300 milligram per minute. But it doesn't happen like that. When plasma concentration is 200 milligram per minute, then only the glucose starts appearing in urine. ठीक है, तो मतलब predicted is that it can occur when it is 300 milligram per minute, but in reality it occurs at early plasma concentration of 200 milligram per minute. This is known as renal threshold. Renal threshold for glucose. Okay, renal threshold for glucose important है. तो इसमें it will start appearing, and this phenomena, this difference of prediction versus reality, this is known as renal splay. ठीक, renal splay. अच्छा, अब last part of renal we will go, that is we will talk about micturition little bit, and that diagram, that is cystometrogram. What is cystometrogram? Cystometrogram is the relationship between the volume and pressure in the bladder, volume and pressure in the bladder. ठीक है, तो this relationship goes something like this. So this value to remember 150 ml, and this value is 400 ml. At 150 ml, this is the first urge to micturate, and 400 ml micturition reflex. Micturition reflex is activated. Okay, so first urge to micturate is 150 ml, and in this diagram if you see there are three phases, 1A, 1B and phase 2. तो यहाँ पे तो as volume is increasing, pressure is increasing. In 2 also as volume is increasing, pressure is increasing. लेकिन phase 1B में देखो that when volume is increasing, pressure is not increasing. So this is due to Laplace law. Laplace law माने when ventricle is filling, there is distension of the bladder. ठीक है, distension of the bladder because it has a smooth muscle. तो smooth muscle जो है उनकी एक important property है, that is plasticity. So it causes the distension of the bladder, because of which the pressure doesn't increase, and this is explained by Laplace law. ठीक है, so this was about all important topics in these four systems, that is cardiovascular system, respiratory system, CNS and renal system. In very small time we have tried to cover as much as possible. So best of luck for your exam, and I hope that you will do well. And don't worry right now that how the exam will go, because worry will decrease the learning. Just give your maximum effort and don't stress more, and just go and write the exam.